we are delighted to have our moderator, Dr. Sukesh Nair, MD Professor of Transfusion Medicine and Immunohematology at Christian Medical College, Vellore, to lead this session. His deep expertise in hematology will bring valuable insights to our discussion. Let's welcome him with a huge round of applause. Over to you, sir. Thank you.
Thank you, Simran. I am also holding something that she was holding. Only two difference. I am not as pretty as her. And second thing is, this is not a quiz, so I am not going to ask whether this is what is the best way of identifying antigen-antibody reaction. Okay. So thing is, though this panel discussion is going to be fairly on general laboratory approach to specific diagnostics in patients, probably to get to early diagnosis as well as care. Sometimes it may even relate to some products that could be manufactured by or unique to HORIBA. Not that many products are unique to HORIBA as far as hematology is concerned, because many of the other people are also reproducing what HORIBA did, or HORIBA is reproducing what others did. So I would actually want to start with the colleagues who work bedside. Normally when we say we'll ask the clinicians first, we must realize that we are also clinicians. So they are mostly bedside clinicians. We are clinicians which work closer to the blood. So they are either pediatricians, physicians, surgeons, obstetricians, intensivists. So we have fortunately two experts, fortunately from the town of Delhi, who are going to give us some insight on what their experience with some of the parameters which sometimes can be taken along with hematology. So I'll start with Dr. Shamik Chakrabarti. Sir, now you have a lot of integrated analyzers. Yeah. Some of them are point of care. Even the point of care also has got a lot of integration. One of them is something called CBC with CRP. We know that CRP is still a specialized parameter in our country, because a lot of physicians, pediatricians, they still order ESR. In fact, the biggest market for ESR in the world is India, because still a lot of physicians, pediatricians, when we actually went in first for automated ESR does ESR very fast. They don't do the 1 hour Westergren's method. And in the old days, we used to report ESR as at the end of 20 minutes, 40 minutes, 60 minutes, what is the sedimentation. So when we shifted to automated, 20 minutes, 40 minutes, 60 minutes just disappeared. There's only one value. So I get a call from an intensivist, Dr. George John. He said, what happened to 10 minutes, 20 minutes, 40 minutes, 60 minutes? I said, sir, I find a lot of significance in that, clinical significance in that. So I said, this newer methodology, they look at infrared aggregation and ruler formation of red cells, and they also look at the rate of sedimentation of red cells and extrapolate 1 hour into 10 minutes. But I still want 20 minutes, 40 minutes, and 60 minutes. I said, you want it? I said, I'll give it to you. So I actually contacted an Italian company and said, can you give me, I can't tell them 10 minutes, 20 minutes, 40 minutes, 60 minutes. I said, tell me end of aggregation, tell me end of ruler formation. First ruler formation, aggregation, sedimentation. They somehow gave it to me. So it was all the ESR results that he requested, I used to report it. All the others just go like that. Then one day I stopped reporting it. They said, why did you stop reporting? I said, he is retired. Nobody else wants it. So sir, now that CRP is not a very commonly asked test, but now CRP is frequently available with certain point of care devices. On a sample, what would you say that as a primary screening, And more than primary screening, triaging of patients, how would these two parameters, CBC plus CRP, help you?
Hello. See, CBC with CRP, as we know, it's a very crucial, important biomarker of inflammation. A patient landing up in emergency department, and if he has a high-grade fever with a tachycardia and high respiratory rate, and we suspect a sign of sepsis, the best thing is to go for a CBC and CRP before you go for blood culture and any other thing. But they are the investigations which will come later on. So if you are suspecting sepsis, we order a CRP. And if we get the CRP results in, say, about 5 minutes, 10 minutes from any automated analyzer, it will definitely help in initiating early treatment, and that will be definitely a boon to the patient. So basically, if a neonate comes to the emergency with clinical signs, maybe sometimes the signs are subtle, and there's a lethargy, and we are suspecting sepsis. So if there's a lethargy, poor feeding, and fatigue, immediate CRP rise of CRP of more than 100 or 500 will definitely help us initiating treatment and save the life of the child. I mean, the baby or adult, anyone, depending on the clinical condition.
Fair enough, sir.
So basically, the clinical, if you're suspecting something, pneumonia, we go for it. If there's a pancreatitis, so it all depends upon the clinical symptoms we are having. But any rise in CRP gives an alarming signal to your brains to start initiate treatment, identify the cause, and start initiate the treatment.
Fine, sir. Sir, I mean, just to extend on the same pattern, same question, do you think that CRP helped you along with CBC during COVID emergencies?
Yeah, definitely. Being a COVID nodal officer myself of Sir Gangaram City Hospital, so it was a boon for us. So it was an inflammatory marker which was available for us, and immediately we could foresee the condition and the future of the patient, and we initiate treatment accordingly.
So it helped triage?
Yeah, it helped in triaging.
Okay.
Definitely.
Because, you know, COVID is in the past, but we can't change the eating habits of the Chinese people, so maybe there'll be another pandemic, we don't know. So I think CBC with CRP, you know, for the first time in CMC, we started using CBC with CRP. Fortunately, they pushed an analyzer where we only put it in one particular place, and that place probably had the best outcome in COVID care.
Definitely.
So, Dr. Rachna, what role can CRP-CBC integration play in pediatric as well as OPD is concerned, neonatal ICU is concerned, or you know, inpatients are concerned?
Yeah, I think, let me elaborate on few points here. Like when we are talking about CRP, it is one of the biomarker which is available and which can guide you in the treatment. Now, for instance, if a child is coming to a OPD and giving a history of fever, now if the child has some symptoms of upper respiratory infection, you may not order any test, but if there are no such symptoms and the fever has been there for a few days, then what you do, you order a battery of tests. In those tests, if you're going to look at your CBC and CRP, that may help you to diagnose a disease. How? I'll give you an instance. Suppose if the CRP is high, but if you look at your CBC, then you can diagnose whether it is an enteric fever or whether it is pneumonia or UTI. Now, how? Because if it is a UTI, the counts will be on the higher side. However, if you're looking at an enteric fever, the counts will be normal, you know, anywhere between 4,000 to 8,000. That is how you can make a diagnosis right in the OPD. And then if you look at, if the CRP is normal, but the counts are anywhere around, you know, leukopenia, then you know it is a viral illness. So it can help you to treat the child accordingly, because the cultures and all are going to take some time to come, and probably these tests will be available within 1 or 2 days. Same for the dengue or, you know, viral infections which are going in the environment or at that time, endemic at that time. At that time, if you're going to look at these parameters, you can very well address the situation and act accordingly. Now, if you come to the IPD, I'll give you an instance, as you were talking about COVID. So, I think post-COVID, we are seeing a lot of viral infections. If I'll compare, then there are a lot of viral infections vis-a-vis your bacterial infections. Now, I've seen a trend where in viral infection, the child is admitted with leukopenia and, you know, low CRPs. However, on day 6, day 7, the CRP shoots up. Now you are wondering whether it is an inflammatory reaction, something like CRIS, or whether it is something secondary bacterial infection. Then again you look at the counts. And obviously the clinical scenario is always there. Then you can decide whether to go for antibiotics, whether to go for immunomodulating agents. So CBC CRP is not just helping you in diagnosing an infection, but it is also helping you in antibiotic stewardship. I am a pediatric intensivist and I can vouch that we treat most of the viral infections who are even on non-invasive ventilation without any antibiotics, because we are quite, looking at CBC CRPs. And if the CRP is on the lower side, we know, and if it is leukopenia, these are viral infections. So antibiotic stewardship, which is, I think, the main agenda of today, we are almost losing on the antibiotics like anything. So here it is playing a very important role. It is, and it is one of the, I agree, if you look at biomarkers, among the biomarkers, it may rise little late and it may take some time to go, but still if you follow the trends, then you can very well decide upon many things. Like I can give you a lot of examples, but I think I'll just go on and on.
So ma'am, thanks for that, but I know that you are a pediatric intensivist. Just trying my luck. Because of neonatal intensivist care is slightly different from pediatric intensive care. One of the pediatric hematologists from Pune, Dr. Rama Manchanda, you always believed in the left shift as an indication of your management of infection, especially neonatal sepsis. And they used to talk about band form to neutrophil ratio. Would you believe in that?
So I think neonatal intensivists have a little different outlook as compared to the pediatrics age group or to the pediatric intensivist. They don't believe in CRPs. They don't do CRPs. So if me and Dr. Ankur, who is a neurointensivist, are sitting together, he will look at me, what rubbish you am talking about.
That's why I said I tried my luck. So I think the same thing goes with adult intensive care also.
Yeah, that's so true.
Okay, so now in the age of AI, I'll probably ask the question coming behind you.
Yeah, come.
If a pathologist or a hematologist tells you, looking at the peripheral smear and the cell counter, because nowadays a lot of cell counters are using AI to identify sepsis. But one pathologist or the hematologist is confident, this patient has got sepsis. Would you still want AI?
No. Because I always call Dr. Handu whenever I'm stuck up with some case.
Yes,
Dr.
I know
Handu.
you work in good hospitals.
Yeah, because AI cannot replace your experiences. I don't know, maybe one day our children will come and tell us that we are wrong. But today I believe that whenever you are stuck up, you always call up your labs and to find out, are you seeing something? Can it guide me? Whether it is an inflammation or whether it is an infection, I'm really stuck up in this case. Can you look at the smear? Then you will always look at the smear and will come back to me with some solutions, with some insight. So I'm
Dr.
sure
Shamit,
maybe
your opinion, because you're working in
Yeah,
a fantastic
I'm
hospital
fortunate.
where Dr. Jyoti Kotwal is there. What is your opinion? Would you trust AI or would you trust your pathologist's opinion?
Definitely pathologist opinion.
Okay. So, warning to the industry, don't trust too much on AI because they take too much unnecessary information when the pathologists actually have specific information.
So here, just one more thing. So it is, AI will be something like Google and the patient will come to you that this is there. This is the disease, this is the medicine. So do you want, I would like to, then I will always tell them that you go ahead and treat your child. So AI will be something like that. But there will be people who will decide that what AI is telling you is right or wrong.
Okay, now coming to Dr. Swati Pai. That's why I came on this side. So I wanted to be far away from her.
Before you ask me a question, can we change the lighting because we won't even know if the audience is asleep. We can't just see anybody in the audience. All the light is here. Can we have a light in the hall?
Now the mic is in your hand. I can guarantee nobody's sleeping in the audience.
We can't see anybody here. It's all dark. See. That's better.
Okay.
Otherwise, after the meal, we are talking and you are asleep. It's not nice.
Fine.
Okay.
So, Dr. Swati, the government of India has Anemia Mukt Bharat initiative. They are main aim at this, not main aim is to get rid of anemia. And because if we come out with something, because we are Vasudeva Kutumbakam, we may probably spread this information across the world. Right now, the diagnosis is only based on hemoglobin levels, which is basically hemoglobinometers. So a lot of hemoglobinometers are coming, both invasive and non-invasive, which only gives you the hemoglobin levels. And if it's a good clinical examination, it's also a good hemoglobinometer. So a good clinician good physician can also identify anemia without hemoglobinometer. But we also know that understanding hemoglobin levels is only 10% of the beginning of approach to management of anemia. Now, obviously, CBC has got many red cell parameters. In fact, we say that managing anemia without MCV and RDW, you're not going to get anywhere. We have those parameters on CBC cell counters. We also have got reticulocyte parameters. The question is, do you think that reticulocyte approach should also be part of Anemia Mukt Bharat in the approach to Anemia Mukt Bharat? Yeah.
So I'm going to ask the audience first. Was everybody aware that there is something called Anemia Mukt Bharat? Are you all aware there is a mission which now you are, right? So first thing is to educate everybody that there is a National Health Commission set up mission called Anemia Mukt Bharat, which started in 2018. So as a concept, this mission is HONMAMON, okay? Full of, authentic and very nice. But the current status is a Japanese word which I just read yesterday called kanashimi, which means sad. So this concept, which is very positive, the current status. So Anemia Mukt Bharat meant that the mission is that by 2030, we are going to be anemia free. We are nowhere near that. Nowhere, we are not even halfway mark. So as pathologists, again, I will tell you something more about the mission. It has a very simple 6-6-6 strategy. They have 6 groups of patients or population they want to identify, beginning from neonates to toddlers to adolescents, and then, of course, the impact on the mental health of these children. Pregnancy, lactating mothers, and anemia of chronic disease or other anemias. So 6 populations, 6 strategies, giving them iron, deworming, supplementing with folic acid, etc., and mental health in that. And then 6-tier program at all levels, district level, basically policy makers. But the testing part of it is only by the finger prick. So there are very big mission, but it's only by the finger prick, HemoQ or hemocytometer, which does the lancet pricking and gives you hemoglobin and PCV, that's all. So now in such a wide screening program in a country which has so much of hemoglobinopathies, which has malaria, which has other causes also, CKD, I don't think that only doing HB and PCV is enough. If now we are talking of technology, we can have an integrated machine, bedside machine, which can give you the indices, RDW and reticulocyte hemoglobin. So now the next question to the audience is, does everybody know about reticulocyte hemoglobin? Do you know that there is a parameter which I think even HORIBA has, RHE? So this is the hemoglobin which is measured in the reticulocytes, not only in the mature RBCs. And that gives you a real-time indicator of the iron deficiency. Now, there is a WHO document about the whole assessment of ferritin as a measure of iron stores. And that whole document in the end has 5 questions. Are there reference ranges for all these populations that I told you? No. What is the right method to measure ferritin? There is no answer. So when we ourselves, we are using iron, TIBC, transferrin, ferritin. I think I don't want to expand too much because if I get the mic, I don't give it up. About what RHE is, I think if we have a system which is cost effective, which can include RC, that's what Sukesh wants me to shut up. But I think I will make a point about this. If you can integrate hemoglobin indices rather than PCV, I don't think PCV helps you as much. We're not talking of dengue and dehydration, but we are talking of iron deficiency anemia and reticulocyte hemoglobin. It is going to add value to this Anemia Mukt Bharat program, which right now, as I said, is kanashimi, which is sad, and it can come to HONMAMON.
Thank you, Dr. Swati. I think puts a lot of insight because we are doing a project for PMGF to evaluate all the available hemoglobin meters that are being used for this program, and results are not very encouraging. We are, the reports are not finalized, but yes, we are providing that. But as you said, hemoglobin is not the beginning. A lot more way to go. Yes. Now I come to Dr. Gaurav. So Lal Path has been an early adopters in innovation. But before coming to Dr. Gaurav, any points Dr. Rachna or Dr. Shamik wants to talk about Anemia Mukt Bharat? About Anemia Mukt Bharat? Because I know that you are very much in the hospital. Anemia Mukt Bharat is the periphery. But any particular pointers you want to advise an industry that when you approach anemia, what should be the philosophy? Nothing, because you are very much there. So
In children, you see a lot of anemia.
Yeah.
And that is because of excessive milk intake.
Yes.
So that's a very common thing under 2 years, and it is not only seen in the periphery, but to the hospital like us.
Yes.
And to our very affluent families also.
Yes.
Because of a misconception of giving a lot of good milk to the children till 2 years.
Yes.
So I think, as you said earlier, by just looking at the children, you can find out that they are pale and something needs to be done for them.
Yes. So obviously there have to be other approaches to pick up that. Yeah. Thank you. So Dr. Gaurav, having adopted latest technology, one of them is being digital morphology. And obviously India is slightly late on digital morphology platform, but Lal Path is one of the earliest. Do you think that it has helped improve the efficiency and quality of reporting? And finally, what does the future hold for digital morphology?
First of all, I would like to thank the senior management of HORIBA for giving me this opportunity. I had joined Dr. Lal Path 15 years back. Back in the day, I have seen, 3-part instruments being used. We used to see the slides. I heard stories from my seniors that Sally's method of hemoglobin was being used much before that. And then we progressed through 3-part, 5-part, 6-part, so on and so forth. But just before COVID, we started using silica microscope. It's just a microscope with a tab on top of it. It will click pictures. You can take second opinions from your peers and seniors. But the main groundbreaking thing that I saw was the incorporation of SIG-2 microscope, which is artificial intelligence driven. The technician just needs to push in the slide. At first, the instrument will check the slide thick hai ya nahi hai, and after that, it will start taking pictures, hundreds of photos. It will use artificial algorithm, artificial intelligence, and machine learning, everything, and give you the diagnosis. And it is very accurate. So I think AI is the future, but it is going to assist us. It cannot replace us in the foreseeable future.
Okay. Fine. Okay. I'll continue on that topic when Rahul Bhargav is likely to be here or unlikely to be here. If otherwise, I'll replace Rahul Bhargav. He was my student.
Sorry.
Thank you. Fine. Dr. Prashant, India has a diversified population. And 1mg, now you're looking after 1mg, has labs across the country. Do you see any challenges in maintaining consistent ranges across India? And are wide ranges of CBC feasible in early diagnosis of diseases?
So, see, we all know that overall what all we establish as a normal range is finally a statistical exercises where we define that this is the normal. And what has been for the whole science, that we don't have reference ranges based out of India so many. There are primarily studies are being carried out on different ethnicities. So first question is it a problem? Yes, it is a problem if we look at early diagnosis, or there are known variations which we know that there is a known variation of say thrombocytes, that is constitutional megathrombocytopenia, or there is benign essential neutropenia, which is seen in, say, Asian American and Africans there. So ethnicity-dependent reference range is something which is we should look at. And on early diagnosis part, so there's an interesting incidence of my just post-residency, a pediatrician only. So that pediatrician told me that even my kid reference range, WBC count goes to 4 to 8,000, you're still going to say it normal. And our pediatric references are very wide. So that is something which they have to look a lot on the basis of clinical picture, and CBC become helpful only in a later part of the diagnosis. So if we have an ethnicity dependent, as well as probably only ethnicity will not work, there will be few environmental factors also, as we know that environmental factors influence overall total leukocyte count on which population will get stabilized. So that is something which one should look at, and conditions like that in eastern part of India, you see that megathrombocytopenia normal, then benign BN, where, and also on what we are talking of, these AI-based interventions, when you will get NLRs and all, they are all dependent on those reference ranges. So if you have a condition of benign essential neutropenia, your NLR will be definitely wrong. So you cannot rely on those AI algorithms if you don't have those very critically defined ethnicity-dependent reference ranges. That is what I look at going forward.
Thank you, Prashant. That's a very pertinent point that you mentioned, that reference ranges have to be population-specific. Now, unfortunately, as far as hematology is concerned, maybe biochemistry too, we don't have reference ranges for our country. Yeah. Though there have been 2 attempts already, all 3 fail. Yeah. I mean, all 2 fail. I mean, 3 fail because I think the 3rd one is also going to fail. That has just been launched.
I'm part of a 4th one also.
Okay, yeah. So it's called the Make in India reference ranges, because there is a lot of problems that exist in our country, and not problems. It's basically some people have diseases which may not be symptomatic. Yes. Like good 80% of Indian populations have Helicobacter pylori. Yeah. But they are not symptomatic all the time. That doesn't mean that CRP may be the same as an European population. CRP may be different. Yeah. Similarly, eosinophils. Eosinophil may not be the same in our country compared to other countries. Monocytes may not be the same in our country because there is a lot of latent tuberculosis, there is a lot of thalassemia in our population, trait population. So it will be different. So I think reference ranges are not easy, but they are necessary. Yeah. Thank you very much. Dr. Ravi, what are the challenges in B2B business, particularly regarding logistics, sample integrity and turnaround time? And how do integrations like digital morphology help in solving these challenges?
So we are facing lots of challenges during the transportation, because transportation is very important. And we have organized so many programs for our associates because we are into B2B and our samples are traveling across the country. So main concern was how to sort it out. Because there were so many samples, those were under rejection criteria. So we have installed more satellite labs. So after having a satellite labs, the issues have gone down. So our samples, now these are not traveling much to Delhi, and we have more labs. So it has given the best solution for, and of course, the HORIBA is playing a very good role into this because we are getting very good support in terms of technology. So that has been sorted out up to a level, but still we are facing challenges.
Right. Now, in this particular question, on the basis of the new NABL 112 guidelines, which has allowed static images to be part of the scope of a lab.
Yeah.
Of course, there are some criteria which the lab has to qualify. Static images means, you can load images in any particular platform after they follow the qualifying criteria, and interpretations can be made. You think that's going to make a huge impact because it's neither AI, neither it's close to AI, neither is it digital morphology. It can be images of anything. Yeah. It can be images of the smear, it can be images of the cell counter, it can be images of the HPLC histogram. What do you think how will that help?
So that digital morphology, as per like 𝐶𝐚𝐫 has also allowed us, so that will be very helpful, because in some of the labs, what the technicians are doing basically, they are scanning the images and they are sending it to the pathologist. And pathologists are supporting maybe from different locations. Now this is all authorized by 𝐶𝐚𝐫 also, that we can do by following up some guidelines.
Provided you fulfill certain criteria.
Yes, yes, correct.
Yeah, fine. Okay, now coming back to our bedside physicians, you train a lot of people. Gangaram is a training center, Max Hospital is a training center. Now these people may go and work in some centers where they may not have good Anil Handus, good Jyoti Kotwals, and obviously you will recommend them, laboratory is a very important part of diagnostics. How would you recommend them to analyze samples? Would you ask them to transport samples? Would you ask them to identify somebody nearby who can be, because turnaround time is very important in both are intensivists. What would your advice be to them?
As you said, the turnaround time is very important and very crucial. I would definitely ask the management at the hospital to procure the machines so that the turnaround time is very less, and to keep those machines in emergency department, ICU, and all those crucial departments, which will be very helpful, rather than sending the sample somewhere else and waiting for the reports.
So I think that this is very important to have. It is very important to have counts and CRP with you. It helps in managing a child much easier. So as he said, I also believe that we should have these reports as early as possible. At least something can be started, and then later on we can review and decide on many other things, depending upon the clinical scenario. But if you are telling me that what I am going to tell my fellows, I am going to tell them that you have to find out a lab or a person with whom you can corroborate and bring out best for your patients.
Thank you very much, Dr. Rachna. Okay, there's one extra question, which is proficiency testing in hematology is quite challenging for many. Why? Because hematology has either hemostasis or cell counts. Now, one of the best thing that proficiency testing program can have is when there is no need to have, worry about stabilizing the sample. The natural sample can travel across all the participants. It's fantastic. But obviously you need to stabilize, because cell counts are not stable, neither are so commutability is a huge issue. And if anything that affects commutability in proficiency testing, it's hematology, whether it's cell counts or whether it is coagulation. Now, obviously people will, when they fall out of the acceptance criteria in proficiency testing program, is a sample was not, the sample integrity is poor. So, the issue is that, do you blame the proficiency testing provider for your failure? Or do you think that you chose the wrong proficiency testing provider? So you must realize that what is the definition of participating in a proficiency testing program or an EQUAS program? It is basically not about accuracy, final test accuracy. But the first part of the definition is that how you compare yourself with your peers. The peer word is very important. The peers basically does not mean another pathologist. It basically means the same cell counter, the same lyse solution, the same diluting solution. That's your peer. So if you feel that if your cell counter does not have a good peer representation, or the program does not compare your results with your peer group who may be there in the program, don't participate in that program. That is not the program you have to participate. So don't blame the proficiency testing provider. Blame yourself because you did not choose the right program. So the definition of participating in PT program is comparing yourself with a peer. The second part is it gives you a chance at accuracy, provided you compare yourself with peer. So because every PT provider has a, if they are accredited, as a part of their program, they do check sample integrity, and they spend a lot of effort and time and money on sample integrity. So don't blame the sample integrity at all. It may be your wrong choice. So if you feel that your cell counter is not in that program as a peer group, that is not your program. Participate in a program, maybe it will be 10,000 rupees more. But next time an NABL assessor comes, don't have the shame of being compared into a program where you're not supposed to be part of that program. So that was the last question in this group. It was not addressed to anybody, so I thought I'll answer the question very well. Rahul Bhargav's questions were on digital morphology, which I think all of you did address quite well. So thank you very much for all your expert opinions. Now I hand over back to the pretty lady who is holding the same card as me. Oh, sorry, the handsome gentleman. You're not holding the, oh, you're holding the same card? Fantastic, good. Thank you.
Thank you.
Oh yes, good idea. Yes. We have 5 more minutes. Any questions from the audience related to what we discussed or anything else related to hematology?
Hello, I'm Dr. Vishwadeep, HOD in the hematology department in Batra Hospital. So I've been working up with Professor Barbara Zebin and as a co-authored the book 101 Morphology Update. And recently in January issue, we published the article together and many other articles also. So we are discussing a lot about the AI thing. So just want to have a 1 minute on, 1 or 2 minutes. See, when you discuss about the AI with Hemat or any other else, you have to know what is AI. So basically, if you read the book, I always recommend this book. It came very, from a few months back. Max Bennett's The Brief History of Intelligence. So if you see there, AI has got the 3 issues mainly. One is the invariance issue. Invariance issue and, you know, the catastrophic forgetting. So what is invariance issue? If you see that if you just, you know, log into your bank account, you will see the CAPTCHA. What is CAPTCHA? It is a distorted numerology, numerics, and the alphabets. So AI, you have to prove that you are not AI, not robot, because it is so much of variance is there, sir. So the invariance issue is there, and catastrophic forgetting that whatever you learn today, you forget everything. That is happening in ChatGPT or any other AI. So that means they have to freeze it at one point for a particular time till they update itself. So that may take 1 month or so. So all that, you know, AI things, they're frozen on time for some time. And this is called catastrophic forgetting. So human mind doesn't have catastrophic forgetting. So next book I will just recommend you, the Michio Kaku's, that is Japanese, but he lives in USA. I'm a great fan of him. So the quantum supremacy. So only the quantum mechanics will be coming, and that will be, you know, like we'll be able to do quantum computation, like Seth Lloyd in MIT. So he has proved already that when quantum computation will be there, then only it will be on par with the human brain. And that has been very much discussed with one of the great, physicist and the first inventor of the taskpad, you know, microchips, Federico Fagin. So I ordered his book, but it's not yet arrived. It is called Irreducible Consciousness. So I think still the human brain has a lot of the things. And suppose I see you, sir, from the back side. So I can know that it is you. Because if you see 4 points, and it all comes, you know, that the convolution hypothesis in the AI, then there will be maybe 1,000 points coming one point, and you do different images, and ultimately you get the images. Human eyes, under retina, it has got, would you believe, 300 million neurons. And they all transfer it to the thalamus and then to the cerebral cortex, where they get a 3-dimensional virtual reality. So we are still supreme, but it definitely helps us. So it is not the time, right, to believe fully on AI, but that AI that has been produced by the HORIBA, that microscopy, I have seen that, I've gone through it, and I've also been recently involved in one of the projects, and it's wonderful, it helps. But please remember, because it is very important to remember, it will take another 150 years of time. And if you don't believe me, just go to the Roger Penrose, the Nobel laureate physicist. He just gave an interview on that. Thank you so much, sir.
Thank you. Yeah, so yes, very much interesting. It's very interesting that despite having so many millions of neurons to your retina, you do a differential count on 100 cells and you correct from cell count which has done differential count on 2000 cells. So cell counter is more reliable than that 100 cells that you see with your retina?
So it's a general question. Do you envisage any role of AI in Anemia Mukta Bharat investigations?
So thing is, AI is not going to be the part of this discussion as such. Digital morphology and cell counter, maybe AI will have a discussion separately, because AI will open a huge Pandora's box, because nothing is known. So when nothing is known, questions are many and answers can be...
I agree with you, Dr. Nair. Thank you so much.